Name's Rob. I'm the Chief Executive of NHS West Yorkshire, and I was a friend of Adam's, and it's a pleasure to be here again at the Adam Bojelian Memorial Lecture. This year we've got Professor Ruth Northway with us, who's going to talk to us about policy and practice and embedding change, which will be fascinating as usual. As with all of these sessions, I always learn something and challenged about something and take something away to implement in my own role. So hopefully that's what you'll all get out today too. Hopefully you've found where all the facilities are. So you head back down towards reception, the toilets are on the left. There isn't a fire alarm scheduled for today, so if it does go off we do need to make the appropriate movements away from the building. There'll be an opportunity in this session today to ask questions following Ruth's lecture, if that's okay. We've got a couple of hours to spend together and it's a good, informal, relaxed environment. As you can see, she's always got really strong arms because she's going to be filming us live today. Usually we live stream these lectures, but that's not been possible today. So what I was always going to do is film the lecture part, but not the questions. So if you want to be extremely challenging or contentious during that period, feel free, because it won't be available on any kind of media unless Mike Chit is going to put it on Twitter or anything like that. Which he will be wont to do if you say something really contentious or challenging or inspiring. It might appear somewhere on social media. If you want to use tweets, then it's #AdsTalk23. Is that a hashtag or an at?
It should be a hashtag. Yes, I got it wrong.
Yeah. And you can tag. You can tag for the poet in it as well, and then as many people will see it as possible. So part of the benefits of these sessions is we create material that people can look at again later, and people can engage outside the room. So please feel free to do that. I'll talk at the end about next year's lecture, but I won't reveal that yet. I'm going to hand over to Ruth. As I do, I'm going to pass across the equipment which allows everybody to engage.
Hopefully that's all working okay. So, good afternoon. Pleasure to be here. Thank you all for being here, and from my perspective, a huge thank you to Zoe and Paul for inviting me to come along. In my job, I work at a university. Often you get asked to give talks, but quite often it's on a particular topic. So the opportunity to speak and have fairly free choice about what you speak about is quite unusual. It's quite daunting as well, because you think, well, okay, what am I going to talk about? So for me, I've chosen something, and I'll say a little bit more about this in a minute, which obviously it's an area of interest to me, and I will sort of position myself as somebody who has an interest in this area, rather than being an expert, because I'm not sure that it's something any of us can be an expert in. I think it's something which we all learn about. So I'm coming at it from that perspective, and it's always good when the technology works. So why have I chosen this? I suppose for one reason, I know that it was a subject which was something which Adam himself was passionate about, so that was a good enough starting point for me. But also, I was thinking about it, as I'm coming now to retirement in a couple of months, it was quite interesting. You sort of start to look back and you start to think about, okay, so what has really been a theme coming through what I've been doing? And for me, I suppose inclusion particularly has been a key theme throughout my career. In terms of, if you want, a commitment to inclusion, which is quite strange given my origins and where I started, because I started working, I'm a learning disability nurse by background. I trained last century, which, it's when you get students who sort of say, but I wasn't even born then, when you feel really, really old. But I trained last century when my starting point for my work was working in large institutions. you know, the very antithesis, if you want, of inclusion. People segregated away physically, socially. But it's always been an area which I've been interested in, and I think even in those early days back in, you know, the sort of the late 70s, early 80s, it was a period of beginning to see change. We were thinking about models of care. We were sort of saying, this isn't quite right here, we need to be doing something different. So we were beginning to see that sort of push. Also, I suppose for me, I've always had an interest in policy. Now, some people think that's quite sad. Other people are as sad as me and enjoy policy. But for me, it's the whole thing about policy and what constitutes policy, what can it do, what should it do? And that's been, again, another sort of theme that I've returned to. In terms of the first academic paper I managed to get published, that was about inclusion and the difference between that and integration, and I'll come back to that point later. It's also been an area of interest for me in terms of research. When I came to do my PhD, I became acutely aware that how I'd been trained in terms of research was very traditional. You have people who do research and you have people who are researched. And, you know, it was very traditional ways of doing that research, which really excluded certain groups from being active participants. You know, in a lot of cases for me, you know, in terms of learning disability, if you wanted to know what people with learning disabilities thought and experienced, you went and asked other people, because people with learning disabilities couldn't take part in research. That was the view. And that is something which, for me, has been challenged throughout my sort of thinking in terms of developing as a professional, but also in terms of my research. And some of the greatest privileges I've had in terms of my work have been working alongside people with learning disabilities to do research. Yeah, not to research them, but to work in partnership with them. So inclusion in research is another area for me which is important. So what I want to look at in this time I've got here is these key areas. The nature of policy and its limits. You know, what I'm not saying is we don't need policy, clearly we do. But what I am going to argue is we need to be realistic about what it can do, and maybe see it as one part of a jigsaw puzzle where we need all of them to actually affect the picture we want. The importance of translation into practice, to think about this relationship between equality, diversity and inclusion, think about some actions which are needed if we're going to effect change, and think about how we assess progress. You know, the question is often sort of given, you know, for children on long journeys, are we there yet? But I think that's a question we need to constantly ask ourselves, and to think whether we will ever be there yet. But, you know, it's something which I think we want to consider. So, policy. What is policy? And I think one of it, I said about working alongside people with learning disabilities, one of the privileges has always been that when you're using certain terms, you get pulled up on them. And I can always remember somebody saying to me, Ruth, what's social policy? Right, okay. Difficult to try and to think about and to explain maybe. But I think, you know, policy will encompass both laws and also what we would refer to as policies. They tend to set out what should happen. Yeah. So, again, you know, you might think I'm sad, some of my students certainly think I'm sad for this, but it's interesting to see how policies are worded. You know, the difference between saying that somebody must and somebody may, for example, in terms of policy, has a big difference in terms of what happens or doesn't happen in practice. It could be advisory or it could be mandatory. And often it's viewed as something which they, whoever they are, develop, and we are either subject to or we have to implement it. So it's nothing really to do with us. Yeah, we're just really the people that have to do it. We have to implement it. And I think that sometimes distances people, particularly in practice, from, if you want, the policy. It appears. Yeah, you know, we've probably all seen the memos which say, you know, please refer to a new policy for X, Y, or Z. And we don't know why it's there. We don't always know why it's there. We don't know how it got there. We don't know who was involved. So it's they do it, and it comes to us. Oh, that's an interesting one. Okay, so some of the relevant policy in the context of this discussion, and obviously I haven't listed it all here, but Human Rights Act is obviously an important one, setting out what our rights are, the rights of everybody within society are, or maybe the rights that everybody should have, which we know that not everybody does enjoy all of those rights. We've also got the Equality Act, which by definition recognises that we've got inequalities. Yeah? So we have inequalities and we need to have certain things in place to try and address those. We also see policies, sometimes they're at a national level, actually sometimes I probably should have put that even at an international level, but we've certainly got them at a national level and also at an organisational level. And equality, diversity and inclusion will sort of be linked into things like HR policies, be linked into things like environmental design, linked into communications, linked into discussions, debates around resource allocation. It's quite interesting travelling up on the train yesterday. You know how you get these conversations that you can't help overhearing? Sometimes people get into very sort of loud debates, and the debate was around, a lot of it was around training and mentoring in industry. And my ears sort of pricked up at the point at which somebody sort of said, yeah, everybody's into this EDI stuff, aren't they? Right, okay, listen in here, a tenor goes. And what was really, really interesting was then that what followed was a discussion about, if you want, whether certain organisations, agencies really got it, yeah, or whether it was just something which was a policy. So we know that it's one thing having a policy, it's another thing seeing something happen in practice. Yeah, we often talk about policy implementation gap. And this conversation last night went along the lines of, there was one organisation, they ticked the boxes but they didn't live it, which for me was the really important bit about, if you want, equality, diversity and inclusion. Yeah, we ticked the box, yeah, we've got the policy, we've done the job. It hadn't gone further than that to really embed it within the culture. And there's lots of things which will influence whether or not a policy actually gets utilised in practice. The one that's often given is resources. Yeah. Of course, we'd love to do this, but it's going to cost too much. We can't possibly do it. Or we'd love to do it, but we haven't actually got the people that train to do it. So a whole range of reasons that come into play there. Another one is awareness. Didn't realise that existed. Or, I didn't realise that I was required to do that. When we did a study a few years ago, we were looking at the implementation of safeguarding policies. And a couple of really interesting things came through from that. One of the people that took part in an interview sort of said, well, yeah, I know where the policy is if we need it. Okay, well that's great. But if you don't know what's in the policy, how do you know to go to the policy? It was always like that, it's there, it's done. Another comment which we got in that sort of study was somebody said, actually, policies don't protect people, do they? It's how they're implemented. Yeah, so this understanding that we need to go beyond just having the policy. And that's a bit about the commitment. Not sort of just having the policy and saying, yeah, job done. Yeah, we can tick that box. It requires commitment to get that into practice. It gets commitment for people to live that on a day-to-day basis. And that commitment, again, isn't just a one-off, it's a sustained commitment. Some of you may have come across the work of Michael Lipsky, which always fascinates me. He refers to what he calls street-level bureaucrats. And this was based on work done looking at human service organisations in the States. And basically what he argued was those of us that are working within sort of human services, so that would obviously encompass health, operate probably in our day-to-day work with a fairly large degree of discretion. Yeah, we make decisions, we have to make decisions all the time, we operate on a day-to-day basis. And therefore, some of those decisions are made totally in accordance with policy. Some of them, You know, maybe we push policy a little bit, we shift policy a little bit, we get round policy, sometimes dare I say. You know, we redefine problems in certain ways to fit policies and things like that. So he argues, you know, what do we then consider to be the policy? Is it what's written, or is it what's enacted on a day-to-day basis? That becomes the policy. It's almost like the culture, the informal sort of culture of the organisation becomes the policy. That's what we do, that's how we do it, that's why we do it. So I suppose for me, what I want to sort of focus on in this session is really thinking about going beyond policy and how do we start to try and think about embedding that in our practice. And for me, I think that requires curiosity. Yeah. Hopefully, you know, it's an area that interests you. You're all here today. You know, how do we get that curiosity for ourselves, but also for other people? We need to develop awareness. Yeah. But also that in itself isn't sufficient. It's about how do we get that next stage? How do we try and put that into action? And I think sometimes the job feels too big, yeah, that people don't know where to start. So I suppose for us thinking about how can we all do something which will actually try and push that action in the right direction. What I will say is that a lot of what I'm going to talk about today will apply across groups. But when we're looking at sort of equality, diversity, inclusion in healthcare, really there's probably two perspectives. One is about the workforce. Now, that is important, don't get me wrong. I'm not in any way saying, you know, that's not something which we should focus on. It's really important that we consider equality, diversity, inclusion in relation to our workforce in healthcare. But I want to focus more, if you want, on the left-hand side. Patients, families and communities. What I found interesting when I was, you know, sort of preparing for this session was when I looked at a lot of the work which was there in relation to the health service and equality, diversity, inclusion, it tended to focus on staff. It wasn't necessarily always there in terms of discussions, or it wasn't there so explicitly, perhaps, in terms of patients, families and communities. And as I said, you know, my background is a learning disability nurse, so please excuse me if some of the examples that I use are from a learning disability perspective, but I think they are examples which probably go across different sort of groups. Oh, I'll get the hang of this by the end. Okay, so equality, diversity and inclusion, which is how I've got it in the title of the talk. Need to think a little bit about what they mean. Also need to think about the relationship between them. Over the last year or so, I've been involved in a few sort of groups that have been working around EDI in different contexts. And one of the groups recently, it's been really interesting, they've made a conscious decision to actually change the wording around in terms of the order. Now, I'm somebody who, if I try to write something, or if I'm supervising a student, they will tell you, I have to get things in the right order. I like things to be in a logical sequence. So I'm going to sort of turn it round a bit and think about diversity and equality, what being the foundations leading to inclusion. So talking about diversity, equality and inclusion, I'll probably alter that again slightly as I go through. I said that the starting point of some of this for me was going back when I was thinking about writing my first academic paper. And at that time, there was a shift in some of the sort of discourse and also in sort of the written word around going from integration to inclusion. Now, you know, being a bit sceptical, sometimes I think, well, okay, are we just changing the word? You know, sometimes we change words in order to give an illusion of changing practice. So I started to read around this a bit more and to try and do some thinking for myself. And I came to the conclusion that they are different. If we're talking about integration, for me, that means about trying to fit people in to what is already there. They're excluded, we try and fit them in, regardless of what we're fitting them into. But it is about fitting in. If we're talking about inclusion, it's a different starting point. We start from the sort of perspective that everybody has a right to belong. We acknowledge that people sometimes are excluded for whatever reason, and so our focus should be on changing the whole, if you want, in order to enable people to be included. So it's more about, I suppose, who has to change or what has to change. And inclusion for me is about, actually, it's everybody's responsibility. It's not about people fitting in, it's about how we go about including people. The other word which sort of goes alongside that in a lot of the literature is belonging. People talk about people being able to have this sense of belonging. So, a couple of definitions of inclusion. What was interesting again, when I started to read around this in more depth, was that a lot of what is being written at the moment tends to be written in the context of human resources and organisations. It's not always about patients, communities, individuals. So these are taken from literature which is primarily focused on looking at it from an organisational perspective, but I think are very relevant. So the first one, inclusion, is the intentional act of cultivating a welcoming environment which enables a variety of different people to thrive. The second one, inclusion could be defined as being included, being embedded and actively involved in what is going on. Now, I don't know whether you're like me, if you're reading things, sometimes you get your highlighter pen out and you sort of manually sort of highlight the bits which you think are important. And I think there's a few bits for me which are really important within that. First of all, it's the intentional act. Yeah? So it's not something which just happens, it's actually something which we have to have the intention to do. And it's about cultivating, so it needs us to work at it. Yeah, so we have to have that intention, or we have to work to achieve it. And it's about, the bit about being able to thrive. It's not just about being there, it's about that sense of what it feels like to be there. And then also being actively involved. Sure, we've all come across situations where people are there, but they're not actively involved in things. So there's different dimensions to inclusion which we need to consider. First of all, there's that physical inclusion, and I think that's the thing which people often tend to think about. Well, people can get into the building, so they're included. Yeah? Well, of course they can come along to that meeting, it's open to everybody. Well, what about if they haven't got the transport to get there? What if they haven't, there's lots of things which can get in the way of, technically they are physically included, but actually in practice there's lots of things which will probably sort of be a barrier to them getting there. But actually being in a setting is one thing. Feeling that you are part of, that there's that sense of belonging, that you're able to thrive is completely different. Yeah? So people might be physically in a place, but actually still feel very, very excluded. Yeah? They might have that sense of not belonging. That might either be, through other people's behaviours, or it may be their own concerns or what have you, but actually people don't have that sense of being able to thrive within that environment. And we need to think about both. So we come on to the question about, is everybody included in healthcare? And I suppose the answer is technically yes. We have a healthcare system which is largely free at the point of delivery, is accessible to everybody. Yeah? We have lots of statements about what our healthcare sets out to do, but there's always a but. Yeah? And we know that there are certain groups who are at risk of being excluded or marginalised. Yeah? So obviously, for me, key group I'd be thinking about are people with learning disabilities, but there's lots of other groups, traveller communities, other disabled people, people from certain sort of ethnic communities, lots of different groups who are at risk, even people perhaps living in rural areas who are at risk of being excluded just because of where they live. Yeah? Lack of access. I know, particularly I live in Wales, we have a big problem in some areas, particularly rural areas, with GPs and dentists. It's very difficult to recruit, people maybe having to go miles to access people. So there are groups who are at risk. So technically people are included, but there's lots and lots of things that get in the way. And that can have a negative effect on people's health and well-being. It leads to health inequalities, health inequities. So it's not just, if you want, the frustration of not being able to be included, it actually has an impact on people's health. And there's reams and reams of literature which talks about inequalities in health. So to give you the example from learning disability, we know that people with learning disabilities are at risk of premature and avoidable death. Yeah? In the last 10 years, we've had the confidential inquiry in 2013, we've got the ongoing leader review, and what we get through from that is that people die perhaps younger than they should, it's avoidable deaths, there are problems in the system, there are problems in care which can lead to those. Even if you go back before that, go back to the 1980s, there was a GP in Swansea, I think it was about 1986 he published his work, which found that actually if you went and you did health checks with people with learning disabilities, you found a lot of health problems which had previously been undiagnosed and therefore untreated. Some quite serious, others which were significantly impacting upon people's day-to-day living. So we've known for a long period of time that this happens. And we also know that they experience a whole range of barriers in relation to appropriate and timely health care. And I've just given you a few here. The first I put there is communication. And often what you hear is, well, people with learning disabilities have got communication problems. Now, as a health professional, I'd like to say, I think health professionals, we've also got a lot of problems with communication. One of my first memories, I'm a learning disability nurse, but we had to do one placement within an acute general hospital. And I can remember going into handover on the first day and thinking I had landed on a completely alien planet because I didn't understand a word of what was being said. I think I was more worried a couple of days later when I was using the same language. But we use jargon, we don't always communicate in a timely and effective manner, we make assumptions about what people know or don't know. Yes, people with learning disabilities may have particular challenges in being able to express their health needs, their wishes, their desires in ways which other people understand. But that doesn't mean to say they don't communicate. People, often their communication is at risk of being misinterpreted. So if you can't communicate to somebody, verbally, because you are non-verbal, that you are in pain, and somebody's coming along to do things to you, actually you're probably likely to hit out or to get agitated. And yet, they're at risk of that being interpreted as being challenging behaviour, rather than actually they're communicating in the only way which is accessible to them. So there is that, communication is two-way, and when we think about communication challenges and barriers to healthcare, we need to think about both elements of that. Lack of knowledge, that again is two-way. When we're talking about access to healthcare, a lot of health professionals still do not have adequate training in identifying and meeting the needs of people with a learning disability. It's not always there within undergraduate medical curricula or adequately there within nursing curricula and AHPs. It is in some cases, there's some really, really good examples, but it is not there universally. And obviously, in both England and Wales, we now do have mandatory training. So I hope that will start to address, hopefully, some of that sort of lack of knowledge. But also, people with learning disabilities can also experience a lack of knowledge. They're not told about their health. They're not told about their bodies. So, they're not told how to use the healthcare system. So that then becomes a problem for them, that they don't, it's not a case of not understanding, it's the fact that they've never been given that opportunity to learn. Some colleagues of mine in Ireland were doing some work looking at access to healthcare and working with a group of people with learning disabilities. And they were amazed because they took them, I think it was into one of the clinical skills labs in the nursing department, where there were bits of bodies around for demonstrating anatomy and physiology. And the people with learning disabilities were absolutely amazed that this was inside them. They had no idea that this is what your lungs look like. This is what, So how do you take control? How do you try and have equal access to a healthcare system when you're not even given some of the fundamental, if you want, sort of basics? Attitudes, unfortunately, there are still negative attitudes which operate. A a whole variety of levels, and systems. You know, remember what I said about integration, about fitting people in? You know, things like standard times for appointments, you know, things like standard letters, all could create barriers. And I say, I've just given you a few there. Those are obviously related to people with learning disabilities, but they could relate to a lot of other groups as well, and there will be similar ones there. So, we want to achieve inclusion, but we're probably starting from a position of exclusion. Yeah. You know, we can't get away from the fact that currently there are a number of groups of people, for whatever reason, are excluded. And some key things which I think we need to consider if we're going to effect change. Some of this has come from work I've done with people with learning disabilities, but also recently in my university we've been trying to work with people from BME communities, because what we're recognising is that when we're recruiting to research, we are not always representative, and we want to engage with people much more to try and make sure that, you know, a range of views, a diverse range of views are represented. I think the first one which comes through in a lot of this work is, you know, if I look and I don't see me, I don't think I belong. So, you know, things like, I can remember going back, this is about 20 years ago now, we have a group of men and women with learning disabilities at my university who come in on a monthly basis and they work with us to look at teaching, research, and a whole range of other things that we've got going on. Then the name that they chose was TRAC, it's the Teaching and Research Advisory Committee. When they first came to the university, they were very, very wary. You know, going to a university, they were expecting to see us all in caps and gowns. Thankfully, it wasn't graduation day, so we weren't all in caps and gowns. But they, you know, that was their perception. Universities were for other people. We're not here. We don't fit. And they would be very loath to walk around. Now, if they come along and you've got a meeting, it'll be, I'll be back in a minute, Ruth. I'm just off down to the canteen, because, you know, people start to see people around. People start to see people belonging. You know, they come in, they do things in our clinical skills suite. But also, it's about things like, you know, even things like promotional material. Yeah, when we put out posters and things like that, if that's not diverse in its representation, people start to think this isn't for me. Yeah, so we need to think about that. Another thing is about bringing in or going out. This came back to us from the group I was talking about, where we're looking at working with representatives of ethnic minority communities. We had our first meeting and it was on the university site. We thought it would be good to invite people in. We had a nice day, there was lots of good discussion. But one of the things that they said to us was, quite often we're expected to come in to your environment. Yeah? Yes, you can make people welcome, you can make people welcome, but maybe people don't always feel that they fit in, they belong there. What we should be doing also is going out. Yeah, it's not always about us expecting people to come into our systems. We need to go out and engage with people wherever they are. The second meeting we actually had in a community group centre, and it was amazing the difference. The discussion was totally different, simply because we were actually in a very different environment, different territory. There was a very different feel to it. Building trust is essential and can't be assumed. I think for me, again, that's a really important one, because, you know, in our eagerness to change things, we can sometimes forget that there's good reasons why people are distrustful of other people wanting to do things to try and include them, etc., etc. Sometimes people have had very bad experiences. It takes a long time for that trust to build up. Knowledge is power. I've already given some examples of that, where, you know, certain groups either have or don't have knowledge, and that gives us advantage or puts us in positions of disadvantage. I think it's also about recognising different types of knowledge. You know, the difference between, if you want, experience and expertise. Both are important. And I think something we really have to be alert to is the danger of tokenism. Yeah. Yes, we'll invite one person along, we'll invite one carer, or we'll invite one person with a learning disability into this really important high-level meeting, and that's it, we've done what we've, you know. Well, of course people are there, they've got a voice, yeah? Or we consult about things, but at a point where decisions are already 9/10 made, and it's quite difficult to actually try and change that. Or, again, things like, I'll use an example from learning disability. Yes, we consult, but it takes a long time to do the easy read, so we'll send that out much later. So the people who require maybe the greatest time to understand and to process and to formulate their thoughts on it are given the least time. Yeah. So we need to be careful. We've done easy reads, so hey, yeah. But so we do need to think about this. So if we're going to promote inclusion, we need to identify and understand the barriers that people might experience when they're trying to access healthcare, when if they want to experience inclusion in healthcare. We need to use that knowledge and understanding as a basis for action. And I think to do that, we need to then go back and to think about what we understand by diversity and equality. So again, diversity, definitions largely coming from organisational literature, which again, I find that quite interesting. It's about uniqueness and recognising our individual differences. Yeah? Different people that inhabit our world, our workplaces, our communities, our families. It's got a lot of meanings to different people. It means that there is an array of differences existing in one place together. This recurring word of difference. And we are all different, and different in different ways. First of all, I think one of the things to think about is not all differences are visible. So sometimes when we're thinking about responses, we are responding to, we can't always see what those differences which we need to take account of. But I think in terms of inclusion and exclusion, we need to ask ourselves, is difference the problem? Or does the problem lie in the perceptions of difference? Difference itself is hopefully is not a problem. As I said, we're all different in many different ways. It's important to remember as well that, people, individuals can be different but equal. Because sometimes there is almost like a hierarchy, but they can be different and equal. But that doesn't happen where difference is perceived as being less than. Yeah? So one group say, okay, they're different, but there is less value, there's less whatever. But there's also a problem when relevant differences are ignored. Yeah? Where we don't accommodate different needs, different views, different wishes. So again, I'll go back if you want to learning disability here, that some of the implications in healthcare. Being viewed as less than. One of the challenges which people with learning disabilities often face, and I'm sure it's the same for other groups, it's what we call diagnostic overshadowing. Yeah? So you're unwell, you have a health problem, doesn't matter what it is, it's to do with your learning disability. Yeah? So therefore you don't go any further. We were talking earlier about hearing impairments. Somebody tends not to maybe respond to sound and things like that. Well, that's because they've got a learning disability. Actually, it's likely to be because they've got hearing impairment. Yeah, so people have this sort of one-dimensional view of people not being viewed as a priority. We saw a lot of discussion and debate about that during the pandemic, didn't we? About when there was a possibility that we were really going to have to look at rationing care, who was the most deserving. There are certain groups who are at risk of being viewed as less than for a whole range of reasons. And another huge area, which I'm sure Zoe can probably say far more about this than me, but not being viewed as having capacity to consent. And that either works, in one of two ways. People either sort of say, oh, well, they haven't got capacity to consent, so they can't have whatever treatment, or they haven't got capacity to consent, so we're going to decide, rather than saying, okay, how do we assess somebody's capacity to make this particular decision? How do we provide information in a way which they can understand? How do we give them the time, the support, what have you, to make that decision? So, and that's almost like that less than. Hopefully the Mental Capacity Act should take us away from seeing groups of people as not having capacity, but I suspect in practice it probably hasn't taken us entirely away from that. But again, it used to be, well, you've got a learning disability, you can't consent. Interestingly, I can remember a colleague talking many years ago who was saying that she did some work on capacity and consent, and this was, I will have to say, this was pre-Mental Capacity Act, but one person with a learning disability she spoke to was perceived as having capacity to have a particular, I think it was an operation, and then they changed their minds, and all of a sudden they didn't have capacity to say, I'm withdrawing consent. Yeah? So other people's perceptions, other people's judgments having an impact. And ignoring relevant differences. One of the things that always, gets me sort of quite anxious is when you go to places and people sort of say, but of course we don't discriminate, we treat everybody the same. If you're treating people the same and they've got different needs, then you're actually treating people unfairly because you're not recognising those needs, you're not responding to them. So, as I said, standard forms of communication. That might seem fairly innocuous in a way, but if I give you an example I came across a few years ago, somebody with a learning disability, with a health problem, going along for an appointment at the GP's. The GP decides they need some kind of further testing in hospital. I'll refer you to hospital. Okay. A few months later, the person with a learning disability goes back to the doctor and says, I'm actually feeling much worse now. And the doctor says, but I referred you to the hospital. No, I've not been to the hospital. When it was backtracked, okay, yeah, the hospital had sent a letter to somebody that couldn't read, who then, because they didn't know what to do with it, had just sort of put it to one side. Hospital had then sort of noted them down as did not attend, and they didn't follow it up. So then it's only when that person's health deteriorated further that they go back to the doctor, and the doctor then has to start that process again, by which time, if it's certain conditions will have advanced and opportunities for early intervention, early treatment could have been lost. Standard appointment times, again, I don't know about you, but even as somebody who is quite sort of well versed in the healthcare system, if I have to go and see a GP, I'm in my head, I'm rehearsing, I've got to get into that first 2 or 3 minutes when I get through the door, in order to get the point across, because the pressure is on them, to get you through. And just failing to make reasonable adjustments, not accommodating people's needs. So why focus on diversity? Again, this is taken from an organisational thing, and you might think, well, why on earth does she use it in this context? But I'm using it for a particular sort of reason. Reason number one is the one that we would hope would be sufficient for anybody to do this. It's the right thing to do. Yeah, it's the moral, it's the ethical, what have you. It's the legal thing to do. Reason number two, it's a representative thing to do. Yeah, we need to make sure that people are represented, etc. And you might think, well, why on earth has she put this in terms of healthcare? Yeah, it's a smart business thing to do. Now, I know within a business sense that would have a particular sort of connotation, but go back to what I was saying about how a lack of focus on diversity leads to exclusion, and exclusion impacts negatively on people's health and well-being. So if we don't focus on it, we're actually storing up more ill health. Yeah, we're negatively affecting people's well-being. So actually it would be the smart business thing to do, would be to prevent unnecessary harm, prevent exclusion so that people can use it. And the reason I've got those there is because sometimes, depending on the arena you're in, when we're talking about trying to get this into practice, you have to use different arguments to different people. For some people, they will be swayed by the first argument, it's the right thing to do. But if you're in the context where you're talking about, resources, things like that, sometimes you're going to have to use that argument. Yeah. So it's about being able to use your arguments in different sort of settings. I also want to just add another bit into this about intersectionality. Yeah. So it's talking here, it's the overlapping connected nature of personal characteristics such as ethnicity, race, socioeconomic background. Connected nature makes an overlap to the collective experience of discrimination. So what does that mean? What it basically means is, as individuals, our lives are shaped by a whole range of different personal factors. So, for me, I'm a white woman, particular age. I work in academia, I run, I'm a run leader. Now, which of those particular, all of that will shape my experience in a particular way. And, and if you were to do it for yourself, you'd probably note down different things. For some people, they intersect, they actually impact upon the experience, and that happens in healthcare. if I give you an example of somebody I came across when we were doing research a number of years ago, a young man with a learning disability from an Asian background. And he was saying how he felt quite excluded in learning disability settings because he was from an Asian background. Yeah, sometimes he was mocked, he was abused because he wasn't British, or he wasn't perceived as he was British, but he wasn't perceived as being British. But then when he went into the background of the Asian community, he was marginalised because he had a learning disability. And, so it's at the two, and it's not as easy as 1 + 1 = 2. It's about how they intersect. But I think in the context of healthcare, probably all services, what we tend to do is focus on one characteristic. We have services which require you to fit into a particular box. So we talk about people with a learning disability. Well, young children, older people, men, women, different religions, different ethnic backgrounds, different socioeconomic, all of that is going to impact upon their particular experiences of healthcare. So we need to think about that. For me, we often, I'm a learning disability nurse, so in a way, my title is a good example of that. But, when we're thinking about this, I often sort of wonder whether a young woman with profound and multiple disabilities, maybe who is 16, does she have more in common with an older man who has mild learning disabilities, or might she have more in common with other people who are 16 and who are wanting to do similar things? But we tend to fit people into boxes and we don't always look at their experience as a whole. So when we're talking about diversity, we also need to think about diversity within groups and between groups and within individuals. And I'll be talking about equality or equity. I said I would probably change another of those words as we go through. Equality, it's a much maligned word, I think. What are we talking about? Equality of opportunity, equality of access, equality of outcomes. All of those are different. For me, I suppose I've increasingly flipped to using equity, because equity is concerned with addressing those differences in status which are unjust, unfair and avoidable. And if they're avoidable, we can do something about them. There are certain things which will always be unequal, but if they're fair and they're just, we could and should be doing something. So achieving equity requires that those with different needs receive different supports in order to achieve equality of outcome. And I think that's really important. So, it's the one size doesn't fit all argument. So if we're going to take action, as I said, going back to what I said, I would probably talk about diversity, equity and inclusion, rather than the original title which I had, which was equality, diversity and inclusion. So if we're going to promote inclusion, what do we need to do? Again, taken from business, 3 key areas. First of all, we need to listen. The argument is that we don't know what we don't know. Yeah? And I would give you a clear example of that. When I came to do research, when I was looking at my PhD, I didn't know what I didn't know. It was only when I started reading some of the work around disability research did I realise that what I wanted to do was probably look at oppression and discrimination in ways which would be experienced as oppressive and discriminatory. So I had to completely swap everything on its head. Some of people were talking about, what they called hit and run researchers who would come in, get the information, swoop off into the sunset, never to be seen again. I struggled for a long time with that because, as somebody who had worked with people with learning disabilities for a number of years by then, all of a sudden I had to question my own sort of practice in the past and say, well, why had I not included people? Why had I not questioned why people with learning disabilities weren't actively included? And some of that's quite challenging, personally quite challenging, but we do need to listen. And then we need to think about, okay, listening's not enough. Again, some of the tokenism stuff that goes on is, well, of course, come along and we'll listen to you, but actually we'll still go off and do what we're going to do. It's about taking action based on that. And that's really important in terms of trust as well, building trust. If people share with you, they have to trust you that you are going to take action. Or if you can't take those actions, give a reason why not. You know, sometimes information is just taken from groups of people and they don't get that feedback. And there's a constant need to rework. Yeah, it's not something which we're ever going to get right. We need to be constantly revisiting and readjusting. But when I looked at that, to me there was a really important omission there. And I think that has to go in first. Yeah? We shouldn't just be waiting for people to tell us. Actually, we should be asking. Yeah? And I'm in good company here with thinking this, because I wanted to include Adam in some way within this, obviously. And he sort of says, you know, we know our minds if you just ask. We'll tell you what you need. Don't think you always know what's best. Let us take the lead. And I think that's one of the key elements, is the fact that, you know, people are not always asked. People make assumptions. You know, I think he's really sort of good at saying, let us take the lead as well. It's not just about us inviting you in, it's about, you know, working with you so that you can take the sort of momentum forward. And also, I just wanted to add, I was going through some data last night on my way up, and this is a quote just recently from somebody with a learning disability. Again, about, you know, people knowing their minds, being able to say what it is they want. You know, my GP should listen more and check if I understand them. They should use language I understand and talk in ways people understand. It costs nothing to use easy read information, but they don't. Yeah? And when you think historically, you know, people with learning disabilities weren't asked, but they're quite clearly able to say what it is that they want from the health service. I think the other thing to bear in mind with that as well is sometimes services are really quite anxious about asking people what they want. I've certainly heard in the past people sort of saying, oh, if we ask people what they want, it's going to cost us an awful lot of money. The counter argument to that I've heard certainly from disability groups is you provide an awful lot of stuff which doesn't really do an awful lot for us at the moment, so you're wasting money. Yeah, if you listen to us, you probably would save money because you'd actually be really meeting our needs. So really important, I would put in the ask before the listen. Is it proactive or reactive? We're not starting with a blank slate. It would be lovely if we were. So we do need to think about identifying barriers so that we can actually either reduce them or ideally remove them. If we move forward, we should be considering diversity at the point of planning and development. It shouldn't be an add-on. Give you an example, case of reasonable adjustments. Equality Act 2010 places a duty on public services to make reasonable adjustments to make sure that disabled people have equality of outcome. If implemented, it's often a reactive strategy, and to some extent it has to be because it's about making reasonable adjustments for an individual. However, it's an anticipatory duty. It shouldn't take any of us by surprise. So we should be planning with that in mind. So in whatever clinical area, have we thought about having information there in ways which is maybe accessible to other people? Have we thought about alternative forms of communication that we can draw upon if people come in and they require that? You know, have we got those things there? How are we able to offer them rather than people having to ask for them? So there's lots of things that are done there. And there are some really, really good examples. Don't get me wrong, there are some fantastic examples of good practice, but they're not universal. Universal design is something which is talked about, and this is about a human-centred approach aims to maximise access to environments and services. I'll just give you a little aside about universal design, which talks, maybe not all differences visible. I was at a conference in a different university a few months ago, and it was a session on universal design. And I walked into the classroom. First thing I noticed was that all of the desks there, they had these seats with the desks, the desks that come over. They were all for right-handed people. And I thought that there was a certain irony in being in a session about inclusive design. Now, for me, it didn't matter for that. I was there for a short period of time, didn't really matter for that time. But what if I was a student in that university and I constantly had to sit there and sort of shift and be in a really uncomfortable position, just because people hadn't thought that actually some people are left-handed? Anybody here join me in that? Anybody other left-handers? No? No, that's unusual. Usually there are left-handers. But, it's something which is a minor thing, and I'm not trying to trivialise people's experiences, but it's about universal design can take a whole range of different areas. Quite often we talk about it in terms of the physical environment, so people will think about things like, have we got ramps in? That's the usual one. If you're lucky, people might think about things like signage, but they don't always think about, maybe some of the environment in terms of the colour schemes, which can be quite disorientating for some people. They don't always think about having the quiet area for people that cannot cope with busy, noisy appointments. Is it thought about when we're developing new policies and procedures? Do we automatically think, okay, how is this going to impact upon diverse groups of people? Rather than, because our usual focus with policy making is to get the standard, isn't it? We need a standard which is going to be applied. But that standard may be experienced differently by different groups of people. So inclusion requires differences are acknowledged, respected and valued. Yeah? Difference isn't a problem. Actually, difference is a strength. We also, I think, I probably should have put this on the earlier slides, but I think we also need to focus on our commonalities as well. We need to acknowledge the differences, but we also need to acknowledge the things which we have in common. It requires, diversity requires different ways of thinking and creativity. If we keep doing what we've always done, we'll get what we've always had. So we need to sort of step out of that and to think differently. Requires a commitment to social justice, collective action across arenas and at all stages. It's not an add-on further down, it's something which should be there from the beginning. It requires leadership, and it also requires continual work. It's something which we constantly have to work at. But having said that, we need to think about how we know if progress is being made. Because if we don't take account, if we don't evaluate, there's a danger that nothing happens. Now, often equality and diversity data are gathered, and again, I looked at a number of sort of documents from health services on this. Quite often that's in relation to staff. It's about how many people, how many staff we have from particular backgrounds, certain protected characteristics, things like that. And I think this is a really good point that's made by Anadina. We tend to measure diversity but not inclusion. Yeah? We like numbers. Yeah, if we can say we had this number then and we've got a bigger number there, everybody's happy. But technically you could have X number of people more involved, but actually they still don't feel included, then there's not inclusion. So we need to remember the difference between physical inclusion and feeling included. And if we want to know whether people feel they belong, it's quite simple, we've got to ask them. Yeah? It's not just always about the numbers, it is about that experience. As somebody who comes from a qualitative research background, you might expect me to say that, but I think it is really important. It's not just about those numbers. And it means that we need to rethink what data we gather, how we gather it and who's involved. Many years ago I read a paper about patient satisfaction surveys in healthcare, and I think there was something like about 20, and only 2 of them had patients been involved in identifying what the criteria were. So basically, those of us in healthcare had already decided about what was important, and then we were going to ask people what you thought about that. Whereas if we started at the point of planning with people and sort of said, well, okay, what do you think is important that we look at? You maybe get a very different set of criteria. So, bringing this to an end then, going forward, I love the work of Maya Angelou, and some of the statements that she made I think are really, really helpful, but this one is probably one of my favourites. Do the best you can until you know better. Then when you know better, do better. And I think for me there's a couple of things that come from that. I said to you before, I found it quite difficult when I started to think about research and why I hadn't actively included people with learning disabilities previously in research. But I was doing the best I could at the time. But once I knew better, I had to change the way I was working. I think also when you know better, do better, it also for me brings about that thing about we've constantly got to be thinking about better. I remember somebody saying years ago, better isn't best. We're not going to arrive at it, but it's that important is that we critically think, we move forward. And Fanshawe talks about inclusion. He said rather than if you're starting from where we are and saying, oh, this is all dreadful, this is awful, what we should be doing is starting from how it might be. work with people to think about what good would look like in relation to equity, diversity, inclusion, and then we can start to think about how do we move towards that. Then we can start to put those bits of the jigsaw in place. And finally, we're going to have obviously opportunity for questions and discussion, but I just wanted to throw back to you, because I think again it's a bit about, it's everybody's responsibility. Rob said, you know, when he's come along to these discussions in the past, he's always gone away with something to think about, yeah, this is what I need to do. You know, I'd encourage all of you to think about, okay, so given what we've considered today, you know, what are you going to do? It doesn't have to be the fact that you're going to change the world, but if you could just do one small bit, which is going to make a positive change, you know, lots of small bits add up to large change. So, thank you all very much for listening.